Hi, welcome to Bone and Soft Tissue Neoplasms at bstneoplasms.com. This is Dr. Bhavin Jankaria, and we have the 50th case. It was titled Lingering Diagnosis, and this was a 15-year-old who presented with pain in the left hip radiating to the knee. These were the x-rays that were put up. This was the MRI set that was put up, and the questions were these four: chondrolysis, osteoid stress fracture, and transient synovitis. So let's just look at the x-rays. There's a little apparent reduction in joint space, and there's focal cortical thickening along the anterior cortex of the neck shaft junction, if you may. And the MR shows effusion. There's marrow edema. And we see some focal irregularity here along the anterior aspect, again, pretty much along the inferior aspect of the neck or the neck shaft junction. And you can see the effusion also reasonably well. But before we dive into this, let's look at the other causes and see if they even fit. Idiopathic chondrolysis typically presents with this wedge-shaped area of altered intensity, typically flattening here, and you get focal cartilage loss. This often resolves on its own, but sometimes may progress to a complete loss of cartilage and joint space. Transient synovitis is diagnosed, it's kind of a diagnosis of exclusion. So you see effusion, no other cause, and then clinically, there should not be any evidence of infection, and these are typically transient and self-resolving. And fractures, I did do this as case 28 across all age groups. But obviously, our case is not a fracture. We're not seeing anything even remotely like an insufficiency or a fatigue fracture. So none of those other options fit. And the only thing is to now prove that there is a definite osteoma. So a CT was done, but the irregularity on the MR was here. The irregularity on the focal osteolytic lesion here is here, which would be somewhere here. And so clearly there's a mismatch, and we just repeated everything. So the repeat MR shows the effusion, the synovial hypertrophy, and the dynamic shows an arterially enhancing lesion, which is at the same spot as the CT and suggestive of an osteoma, which I then ablated, and the patient is absolutely fine. So this is, in a sense, an intra-capsular osteoid osteoma. And when I did this as part of case 18, we went through the epidemiology. Typically, 5 to 25% tibia femur are the commonest involved. Pain is usually at night or early morning, and if the lesion is intracapsular or intraarticular, it may present as arthritis. Often the diagnosis is delayed. The CT findings are typical here, and so are the MR findings. And we've discussed this multiple times in the past. And this is a classic example. See an osteolytic lesion involving the endosteal surface of the cortex here with marked cortical thickening and sclerosis in this extracapsular osteoma. The CT shows the osteolytic lesion or the nidus with central calcification, the vessel leading up to it. The changes on MR where we see marrow edema, periosseous edema, cortical edema, as well as the classic appearance of the nidus of the osteoma. So it's simple, straightforward, very often when the lesion is extracapsular, but just 19% got the answer correct. And that's concerning. So, if this is a diagnostic challenge, then clearly with osteomas, it's a tragedy. And there is a very nice article that came out earlier this year, which looked at the different manifestations of what they call extra-articular and intra-articular. And I have a problem with the term because clearly when you have an osteoma here, it is extra-articular intracapsular. And I think somewhere the authors, the reviewers, the editors just didn't figure out the difference between the two. Because the terminology is extracapsular, intracapsular. It doesn't have to be intra-articular for it to mimic an arthropathy, because what happens here is that you're basically um, you know, going to have effusion and signs of an arthropathy, which can then mislead us and delay the diagnosis. So articular is when you have an articular surface here, which articulates with the joint. And so if you had an osteoma here, you could say it's intra-articular, but this is intracapsular. So a high index of suspicion is needed in each of these cases. Look at this one, marrow edema, pain, left hip, it could be anything under the sun. And since this doesn't otherwise fit in, you should do a CT, which showed us an osteolytic lesion suggestive of an osteoma. And then I ablated it and the patient's pain vanished pretty much the next day. And so one way is to do a CT scan in every patient when unexplained marrow edema. This was my index case, the first or the second patient I ablated in 2004. 18 months the child was roaming around, had one MR done in the past where everything had been missed. And then um, on the last X-ray, the orthopedic surgeon did pick this up. You can see how it can look like an arthropathy, but here you do see an osteolytic lesion, reconfirmed that with the CT and then ablated it. This was another patient who presented with a wrist arthropathy, florid synovitis, also some newborn formation, and this one sclerotic focus here. And because of the arthropathy, the entire focus was on this. And so the patient, in fact, had synovial biopsies, bone biopsy, everything kept coming negative, came for an opinion, and I was convinced this was a nidus that had completely ossified or calcified, did a dynamic scan that showed arterial enhancement and went ahead and ablated it, and the patient became fine in about 2 or 3 days. So intracapsular osteoid osteomas often simulate arthropathies clinically and radiologically. And so the only way to diagnose it is if every time you see a young patient up to the age of 20, 25, who has unexplained what looks like an arthropathy anywhere in along the joints, and then get a CT done to look for an osteoma. If necessary, do a dynamic contrast MR to look for arterial enhancement. And some people these days do a PET CT as well. So I just think MR is a far better and elegant modality than PET CT. So the diagnosis here is intracapsular osteoma. Don't forget the index. We've now hit 50 or 51 cases with lectures and other things. So this is now a booming site, and we've pretty much covered all the major and some minor bone tumors and their mimics. That's my WhatsApp channel if you just want to keep abreast of what I do at other sites and cases. So I talked about why LLMs are going to create problems for radiologists. Then I did this on internal mammary node biopsies, talked about healthcare costs at Atmosvast, and other things as well. So you know where to comment, email, subscribe, etc. Thank you so much for listening to this. Take care.